This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and welcome to our 2018 webinar series titled Advances in Allergy and Asthma. Our webinars are also brought to you by the American College of Allergy, Asthma, and Immunology. The goal of our webinar series is to share guidelines-based information and resources with you that are relevant to your life and your practice. This is a series is how one of the ways that the Allergy and Asthma Network lives out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. This webinar is titled Emergency Action Planning for Children with Anaphylaxis, and we are pleased to be joined today by Dr. Todd Mahr. Dr. Mahr is Director of Pediatric Allergy and Immunology at Gundersen Health Systems in La Crosse, Wisconsin. He is also an adjunct clinical professor of pediatrics at the University of Wisconsin School of Medicine and Public Health in Madison. Dr. Mahr belongs to numerous allergy societies, served on the Board of Regents of the American College of Allergy, Asthma, and Immunology, and has received their Distinguished Service Award in 2008 and a Distinguished Fellow Award in 2014. He is currently president-elect of the college. He is chair emeritus of the Centers for Disease Control and Prevention funded Wisconsin Asthma Coalition. He is very active with the American Lung Association on national, regional, and the local level. Dr. Mahr is the recipient of the American Lung Association's Volunteer of the Year Award for the year 2000 and the 2007 Wisconsin Department of Health and Family Services Partners in Public Health Certificate of Recognition. Dr. Mahr is also very engaged with the American Academy of Pediatrics. Well, let's start talking about planning for emergencies. Thank you for being with us today, Dr. Mahr.
Thank you, Sally, and I want to thank everybody for being online too. We'll start with some disclosures. Not that this is CME, but I'd like to be fair and upfront that I do have some relationships with industry here that's listed, and it really won't impact much at all on what we're going to talk about today. I don't intend to discuss any unapproved or investigative use of commercial products. Here's our objectives. What we're going to do is talk about and describe, and hopefully you'll be able to recognize anaphylaxis. We'll identify the most common causes of anaphylaxis, understand the importance of identifying and treating anaphylaxis quickly, and then really go into a deep dive of how to complete the Allergy and Anaphylaxis Emergency Action Plan that has come out from the American Academy of Pediatrics. So let's start. Well, why is this topic practical? Well, it's very practical for everybody, no matter where you are in the healthcare field, whether it be a school nurse, somebody working in a primary care practice or an allergy practice. Anaphylaxis is common and is potentially life-threatening. Delay in treatment definitely has been shown to be a risk factor for poor outcome. So providers need to recognize and treat anaphylaxis quickly and prepare their patients for the future. So where does anaphylaxis, the term, come from? Richer and Portier in 1902 actually were attempting to immunize dogs to the toxin of sea anemone. And what they found is the dogs that they had previously given and had tolerated sublethal doses of sea anemone toxin died after being given smaller doses. And so they coined this term anaphylaxis, meaning without protection. And it's the opposite of prophylaxis, the term we use quite a bit. Richer actually went on in 1913 to win the Nobel Prize in Medicine for this. How common is anaphylaxis? Well, it's hard to actually get a good grip on these numbers completely because of reporting differences, because of as we get into the definition. But the estimated risk in the U.S. is anywhere from 1% to 3%. So 3.5 to 4 million Americans are at risk, it's felt. And we've got roughly 1,500 at risk for a fatal reaction. So how often is that occurring? Oh, about 150 per year for food-related. Antibiotics by far, we'll talk about later, are the most common at 600 per year, and then Venom is about 50 per year. Now in Canada, there was a 5-year review of about a little over 1 million Canadians, and they found that almost 1% of the population had epinephrine prescribed. But the dispensing rates varied with age, so much more, 1.44% in individuals less than 17, about 1% for 17 to 64, and about 0.32% for those greater than 65. So what can you draw from this? Well, anaphylaxis appears that it's going to peak more in childhood and then gradually decline. So obviously everything's out of, the scope of where you can put all of this for when you're talking to patients, but it's nice to know. So the incidence then ranges from anywhere from 10 to 100 per 100,000 person years. Now, in two different studies published in Journal of Allergy and Clinical Immunology, one in 1999 and then one 10 years later, they looked at what did they see for the incidence. And for the 83 to 87 time period, about 21 per 100,000 person years. And so an occurrence rate of about 30 per 100,000 person years. In 2000 then, when they looked back, it was 49.8 per 100,000 person year, so a doubling. So definitely we're seeing more anaphylaxis, and the highest occurrence was in children again. So that theme is coming through. What I'm going to do next is review something that's very timely, and that's looking at fatal anaphylaxis. So obviously the definition is basically mortality rates and risk factors of people who died from anaphylaxis. This was just published this past year in the Journal of Allergy and Clinical Immunology, and what I've pulled out of it are the practical implications, kind of the take-homes from this article. So for drugs specifically, what they did in their analysis and what they came up with was that drug-induced anaphylaxis is the most common cause of fatal anaphylaxis in most regions where data was available. It is, however, rare relative to non-anaphylactic causes of mortality. So you always have to put things into perspective, so to speak. The incidence of fatal drug anaphylaxis may be increasing in contrast to maybe other causes of fatal anaphylaxis. What they found is that people older than 50 with pre-existing cardiovascular morbidity appeared to be at the highest risk for fatal drug anaphylaxis, and that drug administration errors accounted for a significant proportion of cases. Right? And then I think those of us who work in the healthcare institutions, we know that this is something that's always being looked at, is basically drug administration errors leading to bad outcomes. Beta-lactam antibiotics, muscle relaxants given at general anesthesia, and also injected radiocontrast medium are the commonest reported triggers of fatal drug anaphylaxis. So if we move from there to food, from the same study, they found that fatal food anaphylaxis is quite rare, such that it really adds little overall mortality risk, even in young people known to have food allergy. Reliable identification of patients at increased risk of fatal food anaphylaxis is not currently possible, but we do know that patients with isolated egg allergy or no asthma, so the infant or child with no asthma, appear to be at a lower risk. The risk is obviously higher in the second and the third decades of life, and there's been a lot published on that. So that's the teen years and the young adults. And speculation goes into why is that the case. And I think a lot of us can think of some very good reasons there, that they're not carrying their self-injectable epinephrine with them, that they have some high-risk behavior of basically eating foods that they know may contain what they're allergic to, and taking antihistamines beforehand, and a variety of items like that put that second and third decade at higher risk. Other features of food anaphylaxis management that were associated with fatal outcome were having an upright posture and a delayed use of epinephrine. So we will hammer home through this program about early use of epinephrine. And that delayed use definitely has been linked in a number of studies to fatalities. The upright posture is empty coronary syndrome, or basically empty cardiac chamber syndrome. It's really being upright while you're going through anaphylaxis, which is why you'll see in the plan we want people to be laid down while they're being attended to. Overall, though, given the rarity of fatal food anaphylaxis, our inability to reliably stratify risk, and the limited evidence that specific interventions reduce fatality risk, quality of life considerations should play a key role in driving the treatment decisions for people with food allergy. So next is venoms. So the risk of fatal venom anaphylaxis for venom allergic individuals is quite low, about 3 to 6 cases per million person years. Now that's the case data. It all depends on where you are and what happens. I know in our area a number of years ago, we had a fatal venom anaphylaxis occur in the boundary waters in northern Minnesota of a young gentleman who lived here had a family, a professional, and had never had any kind of venom sensitivity prior to that and got stung and unfortunately had severe fatal anaphylaxis. And so that basically became something well known in our community and set up a lot of calls for people who were very fearful of venom anaphylaxis and increased a lot of our time and energy spent on venom allergies. So the risk factors for fatal venom anaphylaxis are middle-aged, male sex, white race, pre-existing cardiovascular disease, and maybe now they're looking more at some immunologic disorders like mastocytosis and mast cell disorders. Fatal venom anaphylaxis is associated with upright posture again, and then also there's a fatal tick bite anaphylaxis that's associated with squeezing ticks for removal. So it's not really venom, but it fits into this insect vector. So all these risk factors should be considered together with quality of life impairment when making treatment decisions in the venom allergic patients. So again, what overall is anaphylaxis? So there's really comes from Hugh Sampson's article. There's three definitions that we go by, three areas. One is that it's an acute onset within minutes or hours of a reaction involving skin and or mucosal tissue and either respiratory compromise, hypotension, or symptoms of end organ dysfunction. So it's acute onset of a reaction and you have skin or mucosal tissue and you have one other system. Or it could be two or more of the following, occurring rapidly after exposure to a likely allergen, skin, mucosal tissue, respiratory compromise, reduced blood pressure or associated symptoms, and or persistent GI symptoms. And finally, we do need to know it also can be just reduced blood pressure after exposure to a known allergen. So those are the definitions that were defined back in 2010 by Dr. Sampson. But a lot of people think of it this way, that it's an acute multi-system reaction that's caused by the rapid release of mediators from tissue mast cells and peripheral blood basophils. It's an immunologic mechanism that can be allergic, IgE-mediated, or non-allergic, non-IgE. There can be non-immunologic anaphylactic reactions also. Formerly, we used to call them anaphylactoid or pseudo-allergic reactions that can also occur. But I like to actually look at it pictorially. So if we classify anaphylaxis, I think you can say anaphylaxis is either immunologic or non-immunologic. And if we go down the immunologic side, we have non-IgE, so blood products and drugs and dextran and immune complexes. We have what we've really just talked about: food, venom, latex, drugs, the type 1 hypersensitivity reactions. You can have non-immunologic anaphylaxis, and there's physicals or exercise related anaphylaxis, cold related anaphylaxis, there's food induced exercise anaphylaxis, and then there's others: drugs, IV contrast, scaromboid, issues with fish or systemic mastocytosis are non-immunologic. They don't involve the immune system. Idiopathically, we can see that focusing on both non-IgE and IgE. So what do we see in anaphylaxis? So what everybody thinks of, and if you ask questions, it'll be urticaria and angioedema and respiratory problems, and then they die if you don't attend to them quickly. What's not known is that it's not all of these things. It's what we talked about, having some of these symptoms. Usually there are skin symptoms, but not always. And people and a lot of people who deal with patients who have anaphylaxis think, well, okay, it's going to be flushing first, then they're going to break out in hives, then they're going to have swelling of their lips and be really itchy, then the other stuff's going to happen. It's going to march through all of these in a very timed setup, and we'll have time to deal with all of this. And that's not what happens necessarily. Yes, skin symptoms are flushing, urticaria, angioedema, and itchiness. Respiratorily, the nose, you can see symptoms of allergic rhinitis. People who have that can definitely have exacerbations, but other people who even don't have allergic rhinitis but have anaphylaxis can have runny nose, sneezing, congestion. They'll also then usually go on to have dysphonia, stridor, dyspnea. What we worry about then is moving on to asphyxiation and death. In the lungs, so that's in the upper airway, in the lungs, lower airway, wheezing, coughing, chest tightness, asphyxiation, and death. For the gastrointestinal tract, it can be involved in anaphylaxis, and a component of anaphylaxis can be nausea, vomiting, bloating, cramping, diarrhea. People can have significant GI symptoms. So they could have I'll go back one slide, they could have skin symptoms, and they could have GI symptoms, and that technically could be anaphylaxis for sure. Cardiovascular system can, again, be potentially fatal if that's involved, and that's more tachycardia, hypotension, collapse, shock, bradycardia, and death. Some things we talk about when we talk to groups of like school nurses or paramedics are the sense of impending doom, that there are people who are experiencing anaphylaxis and they will basically say, I feel like I'm going to die. I feel like I'm not going to recover from this. I don't understand how I'm feeling, but I'm not comfortable with where I am. Okay? And they feel there's something worse going to happen. Some will talk about a metallic taste, urinary urgency, and uterine cramps have also been described. So what causes anaphylaxis? Well, in childhood, we've got the major players that we'd already reviewed for the fatalities, but you can see food is much more common than drug, exercise, venoms, other, and idiopathic. So we have a number of causes that can be out there, but if we look at the IgE-mediated anaphylaxis, the foods that we really worry about the most, peanuts, tree nuts, shellfish, fish, egg, and milk, medications, beta-lactams and other antibiotics, the NSAID, nonsteroidal anti-inflammatories, any muscle relaxants. Something new that's coming up that is being talked about more are the biologics. And in asthma, as we use more and more biologics, that's definitely something to be aware of. And there was just definitely a very good review that was published on the diagnosis and management of anaphylaxis in precision medicine that was in August of the Journal of Allergy and Clinical Immunology by Dr. Castells, and it really was talking about biologics. So that would be a good reference for anybody. Latex allergy definitely is something that we see and are still seeing. The venoms, bees, wasps, vespids, and then if you live in this, live in the South, fire ants. Allergy immunotherapy. Skin testing is pretty rare, but has been described definitely with some people with intradermal skin testing. Exercise, and then exercise with food dependence. So eating the food alone doesn't cause anaphylaxis. Exercise alone doesn't cause the anaphylaxis, but you eat certain food and exercise, potentially anaphylaxis. And seminal fluid has been related to it, other body or other biologic products that way. Non-IgE mediated anaphylaxis, tops the list is radiocontrast media, other medications, opioids, IVIG, ACE inhibitors, vancomycin has been talked about more so with the red man syndrome, but it can progress on. There's cellular elements that can cause problems, and then the exercise without food or cold, temperature, idiopathic mastocytosis, and then scombroid poisoning is certain fish when the muscle tissue breaks down can mimic anaphylaxis if you ingest that. So how do we identify anaphylaxis? So the biggest thing is history. So when I'm seeing this patient who has this history, I want to know what was the timing of the exposure, what were any associated factors that they know of, exercise, medications, what was the sequence of events and symptoms, treatments and its effectiveness, and I want to do all of that together and actually pull it together so that we can then quickly look at what may be the cause. We might do some lab tests, whether that be skin testing or serum-specific IgEs. Some centers will do challenge tests. And I think for those of you who aren't allergists, referring to an allergist for testing and detailed history is important. This isn't a shameless plug for allergists, but there was one study that looked at the importance of seeing an allergy specialist and undergoing follow-up evaluation. And what it revealed was an inaccurate diagnosis or misidentified trigger in a third of the patients with suspected anaphylaxis. So, the urgent care or ER diagnosis isn't the definitive necessarily. And one of the problems here's a review of anaphylaxis treatment in the ED. This is a random chart review of patients with food allergy presenting to 21 North American ED visits or ED departments. The problem is they were managed 72% of them with just antihistamines, 48% with corticosteroids, 16% got epinephrine, 24% of the very severe reactions. Respiratory meds, 33% like albuterol. Self-injectable epinephrine at discharge was only 16% and only 12% referred to an allergist. So as I just said, of those seen by an allergist after the fact, a third of them, there was a misdiagnosis and or mistrigger. So seeing an allergist is worthwhile, but these were all patients who were presenting to the ER for anaphylaxis. Yet this is pretty dismal when you look at how many got epinephrine at discharge or really got the education they should have had. All right, and there we go. So if you remember nothing else today, we're going to move into epinephrine and the use of epinephrine. So why? Because it is the drug that we need. And so this is a little cartoon of always be prepared. And they say, I thought you were bringing the paint. So remember what the Boy Scouts say, always be prepared. And epinephrine is what we need. And onset of action, a lot of people get confused and they think I can give antihistamines first. I can give a corticosteroid. I don't need to use epinephrine. I see people who've gone to urgent cares and ERs and have not gotten epinephrine, yet we're treated with a whole bunch of other stuff. Yet epi does a number of good things immediately, and it works within seconds. It's IM epinephrine. Antihistamines can be used, but they take minutes to work. Corticosteroids have no effect for hours. So there's something we may consider later on, but nothing right now. So the treatment of anaphylaxis is epinephrine. In the emergency room, then you're talking oxygen, IV fluids might be needed, but delayed epinephrine is a leading cause of bad outcomes. Okay, some individuals may indeed require more than one dose. Studies range from anywhere from 5 to 20% might require a second dose. Lay that patient down with their feet elevated and on their side if they have nausea or vomiting, and call 911. All right, and you'll see that in the action plans. So what about epinephrine auto-injectors? What are out there? Well, we all have heard the term EpiPen. It's a trade name. So there's EpiPen 0.3 and EpiPen Junior, which is 0.15. And now there's the generic version of that. Looks exactly the same as an EpiPen, just has a little bit different labeling put on it. Adrenaclick comes out as a 0.15 and a 0.3. There are differences in how these are activated, whether they have needle guards or not. The EpiPen products and their generic have a needle guard, so when it's retracted from the thigh, the needle is covered up. The Adrenaclick does not, so you'll have an exposed needle. AuviQ is back on the market. There's a 0.15 milligram and a 0.3. This is the product that has audio-visual cues, so it injects on its own and will count for you. They, for your information, will be coming out with an infant dose in the next few months. AuviQ with a little q, it's a 0.1 milligram dose, and it has a shorter needle length. So whereas all the other products have about a half an inch needle length, these will have 0.29 inches, so less chance of nicking bone or causing problems in infants. And the count time won't be a 5. I think it's going to be a 2 or a 3. I can't remember for sure. So, and that'll change on all the other ones. Ideally, epi is dosed by weight, not by age. It's 0.01 milligram per kilogram, but with pre-filled autoinjectors, that's not possible. So what they do, and generally in their inserts, it'll say at 30 milligram or 30 pounds is where you change when a child starts 0.15. When the child is 60 pounds, it's 0.3. We at the American Academy of Pediatrics, and I talk as past chair of the section of allergy immunology, we promote 25 kilograms. You end up underdosing less and overdosing fewer if you change it 25 kilos. But that's not what the product inserts say for the devices. All right. And the 0.1 will be for basically 7.5 kilos to 30 kilos. So these are what we're going to look at here, or what we currently have. Now, there are secondary measures that can be instituted. A lot of you are not in areas that can do this, but those of you are, you can give half a dose of another shot of epi into the injection site, so a bee sting or an injection site of a drug. Diphenhydramine can be used, or any one H1 blocker, ranitidine, or an H2A antagonist. You can give a neb treatment. You can give them steroids. You're more looking at the late phase reaction, et cetera. And for refractory hypotension, you can look at dopamine or glucagon, et cetera. But again, that's an ER or hospital-based management. So if you're looking at, I want to be prepared for anaphylaxis, what should you have? Well, if you're a clinic setting, you definitely need epi, 1 to 1,000. You need oxygen, and you may need the ability to do some IV fluids, so tourniquets and syringes and that. Not needed. I mean, if you basically want to handle it, it's having some self-injectable epinephrine. All right. If you want to enhance your crash cart, so to speak, for anaphylaxis, so one-way valve face mask, oral airways, O2 sats, nebulizers, etc. And so this list is really built for more clinic-type progress of people who want to enhance their preparedness. After anaphylaxis, keep in mind that accidents are never planned. So review the trigger and the avoidance, recognize symptoms early on. So go back and say, well, what really happened? What did you remember from this? Okay, those are some of your symptoms. Let's react more quickly next time, etc. Take that time to educate all caretakers on a better plan, and create that plan, emphasize and validate self-injectable epinephrine and its use. I see a number of patients who, even though they've been educated, they decide not to use it. Action plans are good for home or school. They give the triggers and the symptoms to look for, the medications to use with the dose and the order. Where the medications are kept and access should be known by everybody at whatever center you're in. So if you're daycare or a school, people need to know where are these going to be. Okay, and what other people should do, like call 911. And then in your office, allergy emergency practice drills are always good to have. And then so everybody knows what everybody else should do. So these are what action plans can look like. There's just a variety of them. Here's one that people have been familiar with, the food allergy action plan. Other centers have had them. They're all kind of the same. Some use severe and mild symptoms, have pictures on them. But what we are really pushing is the fact that national and international guidelines, as well as AAP clinical reports, all recommend the provision of emergency action plans to pediatric patients that are at risk for anaphylaxis, in addition to a prescription for epinephrine autoinjectors. The CDC also has guidance for managing food allergy in schools, and it supports the inclusion of written emergency plans. If you want, there's two good clinical reports that came out, guidance for clinician in rendering pediatric care. One is on the guidance in completing the written allergy and anaphylaxis emergency plan, and the other is epinephrine for first aid management of anaphylaxis. And both of these were published in Pediatrics, and we can get you the references. So this is what the AAP's new allergy and anaphylaxis emergency plan looks like. This is a screen print from what you get when you go online at www.aap.org/AAEP, as outlined there. What's highlighted in blue, these areas that are in blue, you can fill in on the website. So you can fill them in on the website. It won't be saved. You'll fill all of this in and then print it, and there's a space there for the signature if you want to. You can put the photo there. This was developed with the support of and advice of various committees, councils, and sections within the American Academy of Pediatrics. So the AAP doesn't put its logo on things very willingly. So it took a long time to get this through the process, and now will be updated accordingly as we move forward. The plan takes into consideration several aspects of anaphylaxis emergency care, including the recognition of signs and symptoms, so that you can see here, and the treatment. It serves as a guide for the patient, caregiver, and our school personnel to determine how to treat allergic reactions. That's its intent. What I'm going to do now is drill down in some of these sections and show you a little bit more. So the top of it here is blown up down here, and so the date is right up here, so we can have a date to determine when it was created by the healthcare provider, the demographics of the child and their weight. You can do allergic triggers added in here specifically, so it can be either like tree nuts, peanuts, venom, or whatever it is. Presence of asthma, since presence of asthma has been associated with an increased likelihood of having respiratory symptoms during a reaction and make it more difficult to treat, you can check that off. And if yes, then there's a higher chance of severe reaction, so people can know. Same way with if they've had anaphylaxis prior to that. And then there's the two decisions. Can the child carry their medication themselves? Can the child give him or herself their medication? And this is for, again, the healthcare provider to determine with the parent. But child's ability to self-carry, in a survey that was done looking at of AAP allergy and immunology specialists, most of them said that they felt a 9 to 11-year-old could recognize anaphylaxis and a 12 to 14-year-old could self-carry and self-administer, just to give you some guidance. So, I mean, if you've got a 5-year-old and you're saying, yep, a 5-year-old could carry it and give it to themselves, you better be on some firm footing as to why you're saying that to the school. So most of us, it's again around age 10 to 14 that we begin to say they will recognize anaphylaxis and they can actually give it to themselves. This middle section then, what to look for, these are the signs and symptoms, okay? So for severe allergy and anaphylaxis, here's what you look for. if the child has any of these severe symptoms after eating food, being stung, or whatever their allergen is, give epinephrine. Shortness of breath, wheezing, coughing, skin colors, pale or bluish, weak pulse, fainting or dizziness, tight or hoarse throat, trouble breathing, swallowing of the lips, vomiting or diarrhea, especially if combined with other symptoms, lots of hives or that feeling of doom. Okay, what's recommended? Early use of epi. Inject epinephrine right away. No question. Note time, call 911, ask for an ambulance with epinephrine, tell the rescue squad when the epinephrine was given. Stay with the child, call the parents, all the rest of it is here. You can give other medicine if prescribed, okay? Don't use other medicine in place of epinephrine, okay? So there is a box for a special situation here. In some circumstances, early epi may be needed even if no anaphylaxis is already occurring, and that's this box. This was put in because we had a lot of feedback from providers that have had this problem where the child has had an extreme severe allergy to either an insect sting or to foods. And so we wanted to pull that out and have this checked so that you could put it in there, say, even if the child has mild symptoms after a sting or eating these foods, give the epi. Okay, it's going to be not frequently checked, but it was enough so that we decided it needed to be built in there. Then down at the bottom, for mild allergic reaction, what to look for. So if the child has any mild symptoms, you monitor. So they can include itchy nose, sneezing, mouth, a few hives, maybe some stomach nausea or discomfort. You can stay with the child, watch them closely, give antihistamine. If prescribed, call the parents or the doctor, and if symptoms or severe allergy anaphylaxis develop, use epi. So now this was controversial indeed. And so the use of antihistamine is here, and it's included as an option because this plan provides instructions for managing allergic reactions with a wide range of severities. And several studies have examined reactions to accidental or intentional exposures and noted that 30 to 70% of reactions are noted as mild in severity. So in that event of a mild reaction involving isolated skin symptoms, mild facial or oral symptoms, or mild GI discomfort, none of which meet the criteria for anaphylaxis, the use of oral antihistamines might be an option. Why? Well, if epi is stipulated that no matter what, epi should be given, whether they, if they are known to be peanut allergic and they ate a bar that has manufactured a facility with peanuts and they start to say, my mouth feels a little itchy, if you have a plan that says you give epi then, that might cause problems, and a child might be hesitant to voice any symptoms for fear of epi use. If an option is needed where antihistamine alone is not permitted, if school or local policies don't permit delegates or designated individuals to administer antihistamines, and sometimes that gets into a problem where they can't make that decision. They're not empowered to do that. They're black and white. Well, then you don't fill in the histamine part of it. From there. And then at the bottom, we have here the parent and guardian signature and date, and then the physician or healthcare provider signature and date. So that's the plan on the front page. The back page looks like this, okay? And it has that area where you can type in additional instructions, okay? Any statements of disability, and then all the contact information for the parents, 911, the doctor, the parents or guardians, etc. So yes, we could put more on this. This was, again, a consensus of committees, sections, and councils, and it took a while. So overall then, national and international guidelines support the use of a written allergy and anaphylaxis emergency plan. And this enhances the care of children at risk of anaphylaxis. So the AAP finally has stepped up through pushing of our section of allergy and immunology to come out with this, that we could have a standardized plan that hopefully everybody can use and feel comfortable with. Plans differ in content and treatment recommendations, and that leads to a lot of confusion. That's why we wanted to try and have a universal plan. The allergy and anaphylaxis emergency plan, as developed by the HCP, would be beneficial for patients who are at risk of anaphylaxis and those who have been prescribed an epinephrine autoinjector. The written plan may serve as a guide for patients, for parents, for non-family givers, and school personnel. Epinephrine, oops, sorry about that. Don't know what happened here. Oop, got to go back one. There you go. Epinephrine is the medication of choice for the initial treatment of anaphylaxis. Early administration is associated with optimal outcomes. If exposure to an allergen triggers only a mild symptom, observation only with initiation of treatment of an antihistamine may be appropriate. That one is controversial, but it is appropriate. And then this American Academy of Pediatrics Allergy and Anaphylaxis Emergency Plan allows HCPs the opportunity to individualize the treatment plan according to the child's history, family input, and local regulations. And with that, I'm going to turn back over to Sally and say, do we have any questions?
Well, there are quite a few questions here. The very first one I want to take, though, is telling people how to, once again, retrieve the certificate of attendance. If you look on your control panel, you'll see an area that says handouts. Some people have told me that they don't see that on their control panel. I know that some people do, some people don't. If you have any problems, first of all, try to go to the handouts section, try to just download that and print it now, because at the end of the program, you won't be able to. If you have any troubles, email me tomorrow. My email address will be in a follow-up email that comes to you exactly one day after the presentation, and I can send you one. So it's just nice when I don't have to send 800 of them. So if you can print it, that's great. If you can't, certainly let me know and I'll be happy to help you out. Okay, so Dr. Mahr, our first question for you is, someone is asking if you would please discuss issues that may occur with individuals going through peanut desensitization. So she's asking if a dose or two is missed of the daily peanut sprinkles and then resumed, what could occur?
Well, I mean, it's theoretically that if it depends on where they are in the desensitization, but technically, yes. That's why desensitization is still considered somewhat experimental. Some people are doing it, but for all of these oral immunotherapy desensitizations, if you miss a couple days, probably that child is at risk. That the next dose may cause problems, and you should be in touch with whoever's supervising that to backdose, cut down, etc. Which is why you should always have self-injectable epinephrine available, because you are going through this desensitization. I can't tell you. It depends on that individual person's peanut sensitivity, how at risk they are, whether 48 hours might cause it, or it might be 36, or they could go 4 days without it and not have a problem. There are lots of individuality there.
Okay, another question is there an age at which anaphylaxis peaks?
Oh, good question. Yeah, I think, anaphylaxis itself, we don't have that information as to when you would have anaphylaxis. If you look at fatal anaphylaxis or anaphylaxis that causes more significant problems, it's actually the teen years is where we see it the most. And part of it is all of those other things we talked about, the fact they're not carrying epi with them, they're doing high-risk behavior, some of those things. But definitely childhood years and most likely the teen years.
Okay, thank you. This is a question that you've probably answered throughout the presentation, but it is such an important one, I think it bears discussing again. And this person says, my question is about standing orders for nurses to give epi when we have a student without a previous diagnosis of a food allergy displaying symptoms of food allergies. Should our treatment plan include Benadryl or just the epinephrine and albuterol?
Well, that's a very unique focused question, and I would take this time to refer people to a webinar that was done in September of 2017 that's archived on this same network on allergy and asthma in the school setting. So you may want to also watch that one if you hadn't caught that one. Sally was one of the presenters of that, but basically that specific question is very unique, because you're basically saying we have undesignated epi available, and we have a patient who's coming in who we think is maybe having anaphylaxis to something, ingested a food that might be the culprit, but we didn't know it because they had no prior history. When should we treat that patient? You'll never be faulted for giving epi. Giving one dose of epi to a patient will almost invariably never do harm in a case like that. So I would always err on the side of giving epi if you're going down that route. Now, if it's the mild symptoms, as was described a few slides ago in here, if it's just these mild symptoms, okay, then I would think, if it's a little bit itchy nose, sneezing, a few hives, some of that, well, then maybe you can watch that child. But again, what you just told me is a patient that you don't know what their history is going to be. So I would err on the side of so that's not a child as a school personnel. You say, well, okay, I don't think much is happening here. I'm going to give you a little Benadryl, go back to class. No. This child stays in the nurse's office or wherever that happens to be and is going to be observed, and the parent needs to be called.
Well, I
Okay.
always like to think of mild allergic reactions and anaphylaxis being apples and oranges. And if they get to
Yep.
anaphylaxis, they need the epi. So I worked with an allergist in Rochester, New York, when I was a school nurse there. And he had a great rule of thumb. He said, if you say to yourself, gee, I wonder if I should give an epinephrine's the next word, go ahead and give it and don't finish the
Right.
sentence. So
Yep.
someone was wondering if you could post the reference for the fatal anaphylaxis article.
Sure, I can get that to you, Sally, and we can
Terrific.
put that online. Yep.
Okay. Now, when someone's asking to clarify, if a student in a school has exposure to an allergen and has GI symptoms and rhinitis, is the recommendation to treat with epinephrine?
Well, no, they don't fit the initial qualification of they don't have the skin symptoms. So for most of those, it's skin symptoms and one of the other ones. So it's not two of the other ones necessarily. It's skin symptoms and one of either GI or skin symptoms and the rhinitis and all of that. So you're picking two very mild symptoms. And so I would err on the side, if I know that patient has prior had symptoms. So it goes back to the last question. If you know they're allergic, if they've had anaphylaxis in the past, by all means, I would probably give that person epi. Now, if it's somebody who their prior symptoms were very mild, they broke out in a rash, they got tested and their skin tests were positive, but their only prior reaction was hives, then you might want to kind of drag your feet a little bit. We're into the gray zone on a lot of these questions. So, it's really basically how that patient presents and where they are. So it's a good question, but I don't have a definitive answer.
And that's where good medical and nursing judgment comes in, isn't it?
Correct.
This question is, what is the news about A1 versus A2 proteins in dairy milk? That's
that I don't know.
Exactly what we're talking about today. So
yeah, so I'd have to defer that for later.
Okay. Another question is, if someone has a recent diagnosis with food allergies, it's almonds, cherries, hazelnuts, peas, soy, and squash, should they carry an EpiPen?
Well, yeah, if they truly have had food allergy reactions, they need an EpiPen.
Sounds good.
Did I miss something on that question?
No, I don't think so. I think it was just one of those moments where someone was just asking for that much more.
Double checking. Yep.
Double check.
Yep. Yeah. If they've had food allergies and they've been diagnosed with food allergies, I definitely would say they'd have to have an EpiPen. That list was fairly long. Now, all of those that I think you listed could be oral allergy syndrome causers, meaning itchy mouths only. In people who have hay fever or allergic rhinitis to some of the weeds, trees, grasses, if they eat fresh cherries, if they eat peas, if they eat carrots, they can sometimes have an itchy mouth. If that's all they've had, then they probably don't need an EpiPen. But that wasn't your question, but I wanted to clarify a little bit.
Thank you. A lot of people get confused with oral allergy syndrome and true allergies, so that's a great thing to discuss. Someone's wondering if you know the precise date when the Auvi-Q infant dose will be available.
I've just heard it's going to be probably late first quarter, so probably March, April. I think it's getting launched at the Academy of Allergy meeting, which is the first week in March, but I'm not sure that's when it would be available, but I know that's when they're bringing it out to the, launching it to the medical community. Would be at the Quad AI meeting, which is in March 1st through 5th, I think.
That's pretty exciting. Someone is wondering if the PowerPoint discussion can be reviewed because they were interrupted at work. Well, we totally understand that. And yes, it will be recorded and it will be posted hopefully within 48 hours. So,
but don't ever let somebody interrupt you again. No kidding.
In the line of work we're in, it's amazing we ever get to do anything for more than 10 minutes. Okay, here's a question. This person says, I'm a school nurse. Do you have suggestions on how to have the doctor complete this for the school? It seems that most students with an allergy do not know about this plan. Therefore, they do not bring an emergency action plan.
Yeah, which is why I really want you to have that, the website there. I'll try and get that up again for you, the www.aap. So it's online. You can just go online and print it off. Here we are. Sorry about that. www.aap.org/AAEP. So, if you wanted to, as the school nurse, print these off and send them out, and they don't have to be filled out online. You can print good copies of them. That's what we've done in our area. And this could become your emergency action plan. We would love it. Okay. We think that's fantastic. It will be updated. So we're right now down at the bottom of this, you can see that's what listed as checkboxes, epinephrine dose 0.15 and 0.3. We'll be adding 0.1 to this fairly soon. So, as soon as we can clinically do it. So.
Well, and that's something we wouldn't necessarily see at school, so this would still be very appropriate for school. I would just like to take a second to just address emergency plans, because there are lots of them out there, and some of them are evidence-based and some of them are not. And I think that it's very important for nurses and parents, as well as practitioners, to be thinking about, you want to use an emergency plan that is evidence-based. This one is, and I think this is one at the network that we are really encouraging people to use when they're asking, well, what plan should I use? And some of the plans have gotten outdated. This one is new. It's well thought out. And Dr. Mahr's not kidding that for the American Academy of Pediatrics to put their logo on anything means that it's been through rigorous review. So I would just encourage, especially nurses, if you've got a plethora of different plans at your school, if you can start moving your parents towards using this one, or start asking the practitioners that are using an alternate plan to please start moving towards this one. I think it's great when we have a more standardized plan at school, but then also I think this plan should be the standardized plan.
Yeah. And what's nice is by having it at the website here, it's always going to be up to date. You go to that website, you can do it. So in our office setting, I try and create them online when I'm in with the patient, but that doesn't always work because you don't always have that much time. So pre-printing it makes some sense, and then you just fill it in by hand.
Sounds good. How do you feel about the non-designated anaphylaxis orders that many schools are adopting?
Yeah, I mean, that's a state-by-state type of issue. There's a lot of things that surround that, and we don't have that much time left. But, I think having undesignated epi is a good thing. With that, then you have to decide who's going to pay for it, how the funding is going to come, and then who can use it. And I think if it's a plan that basically says, here's what anaphylaxis is, and here's how you can use it, and you work that out with your medical director for your school or wherever, and you've got a nice concrete plan, I think they're very useful. They will help out. Okay, it makes a lot of sense because there are definitely going to be first-time anaphylaxis occurrences that occur in schools where you didn't know that patient was allergic. At least you've got something you can do and call 911.
Well, and this really, this ultimately really just helps the kids, and but every state law is going to be different in every state. This isn't a national law; it's state laws, and they're very different state to state. So be sure you know the guidance in your state, and also this also avoids a really deep issue for nurses, because in the old days, before stock epinephrine was in place, if you had a student that was experiencing anaphylaxis, you had to make a quick decision whether you were going to do something outside of your scope of practice and use another child's medication, or watch the child fail quickly. And now the stock epinephrine is a wonderful thing for nurses as well as for students, because you no longer are stuck in that moment of, what do I do? And so I'm a huge fan of stock epinephrine. So somebody's asked, this is a great question. Can we use an anaphylaxis emergency plan without a doctor's signature?
Well, that again is a state-by-state issue, or actually can be even a local community issue. So I don't know if you're a school nurse asking that, or if you're somebody who says, hey, I just happened to see this person, and everybody's covered. Almost everyone is covered under Good Samaritan law. And so if you come upon somebody and they have an EpiPen on them and they're unconscious, nobody's going to come back and you're not going to be held responsible for that use. That goes out the window when you're talking about a school setting and some of these other settings. So you have to know what the laws are locally. And I don't want to get either of us in trouble by trying to answer that.
I appreciate that. So next question is, how long do you recommend holding the EpiPen on the skin?
Well, actually, what's changed significantly for the devices is that length of time. The AviQ is a unique device in that it injects and retracts almost automatically. So it's a gas-powered cylinder, argon gas, and when it clicks, it basically is injecting and retracting almost within like a second. So their new one is going to count 3, 2, 1. You can remove it. It might be 2, 1. I can't remember whether it's 3 or 2.
It's 3.
It was it 3, and
yes.
the old one was 5. So 5, 4, 3, 2, 1. So 3, 2, 1 done. EpiPen used to say 10, and they've dropped it. Okay, to basically 3 to 5 seconds, I think, is what you need in any of them. What you want to do is make sure you have it there firm enough so the injection occurs, and almost for all these devices occurs almost right away. And you don't want to be pulling out while that has happened and squirt epi all over the skin. Anaphylaxis is not treated by topical epinephrine on the thigh. Okay, so you want it in the muscle, and it can go through pants. You just want to be careful you don't hit cell phones and things like that. And I tell people, do a good 3 count, 1, 2, 3 with any of these devices, and that's all you really need. The risk was, yes, they were seeing some infants and other ones who, with the needles that stay out, ripping into the muscle, ripping into the skin as this kid is squirming all over. So I think a good 3 count is all you need.
Sounds good. Someone would like to ask you to speak more about positioning after suspected anaphylaxis. They were concerned about the non-upright position.
Yeah, it's again, if you can, the ideal situation is so the risk is that as the patient is entering anaphylaxis, if they're having some other cardiac issues and other things, that if they're upright, they may have problems by having empty ventricular syndrome. So because they're pooling their blood, they're not pumping as well. Their blood is still, their heart's pumping, but it's not returning as well. If you lay them back, you get natural blood flow back to the heart. So you remove that gravitational issue you have to overcome. So, if that's not possible, if you can get them into a chair and at least sit them down or get them down, but you'd want to do that almost anyway, because these, self-injectable heparin is a shot. It hurts. And so you also might have somebody who, passes out or has a vasovagal on top of you. So getting them to the ground is always a good thing.
Oh, the follow-up question is, what do you do if you have students who don't want to lie down because of the difficulty breathing or they feel nauseated?
Well, at least sit them down. So at least get them in a chair. If you can, just don't have them be standing up, and if they can recline in that chair if they want to a little bit, but they're going to, with the epi, they're going to start feeling better and their breathing is going to improve quite rapidly, ideally.
Okay. Someone's wondering if there's a training on administering epinephrine. Would you like me to take? Oh, okay.
You take that.
Okay.
Please.
There is a training. There are a couple of them. One of them, if you want a full training for allergies at school, a great spot to go is allergyhome.org. That's got a great school staff training. If you're looking simply to train them to administer epinephrine, the National Association of School Nurses has a program called Get Trained, and that will provide you literally with everything right down to a script for how to do the training at school. So, and someone's
if you want training on the individual devices, each of the devices have training videos on their home pages.
Okay. If a child is almost at the weight for an adult dose of epi, for example, my son is 58 pounds and uses an epi junior, should I request the adult dose to be on the safe side?
Yes.
We
changed, so American Academy of Pediatrics recommends changing at 25 kilos. So your son is 26.3 kilos. So yes.
Okay, someone says, I'm an emergency room nurse by night and a school nurse by day. Well, God bless you. I've had rescue personnel question the position I place patients in after epi is given and stand walk patients to the ambulance. Well, you really have answered that. But she said, how do you feel about that?
Right. Yeah, I would, after I give it, I'd let them lay for a little while, like we're talking a couple minutes, if you can, and they're not in any danger and they're not at any risk. And then if they're recovering, which they should be by then you can walk them to the ambulance or whatever. Yep.
Okay, this is a parent of a 10-month-old with milk, egg, peanut, and tree nut with an IEG greater than 100. Are there any chances of outgrowing these allergies?
Never say never. So yes, there is. And there's also chances of being able to possibly desensitize that child in the future. That's where a lot of the research is going.
Okay, I'm looking through these. We've answered quite a few of these. I'm just trying to read them really quickly to see if they're new.
Okay.
Oh, do you have any comments on alpha-gal allergy?
Well, I mean, the tick-borne. It's in relation to red meat and tick and tick bites, and it's kind of a strange type thing, but it is in the southwest and southern part of the United States. So I think it's becoming more common, and it's really that awareness will increase so that people will pick up on that. But those people do need to have epinephrine.
Okay. Well, I think that we have time for just one more question. The question is regarding the antihistamine. Does it matter if we recommend Benadryl or one of the non-sedating antihistamines?
Yeah, if you really are going to use an antihistamine, you want to use one with more rapid onset of action. So that would either be diphenhydramine Benadryl or Zyrtec syrup could work. Claritin is a very weak antihistamine, so I would limit it to either of those two. So cetirizine liquid or diphenhydramine liquid.
Well, Dr. Mahr, I've never seen people ask this many questions on a webinar. There was still a tremendous number of them here. So if you do have additional questions, please email me and we'll do our best to get you your answer. But we are out of time, and the last question simply said, thank you very much. And I'd like to thank our listeners for tuning in today, but also thank Dr. Mahr as well. So
My pleasure.
For our listeners, if you'd please join us next month for our February webinar, we'll be talking about AERD, or aspirin exacerbated respiratory disease, with Dr. Tanya Laidlaw. She will be joining us on February 14th at 4 p.m. Eastern Time. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page of our website. Also on our website, you'll find our resource for schools and families titled Allergy and Anaphylaxis, a practical guide for schools and families. Look under Outreach and Special Publications for this guide. This is a free download. There's also a bonus section available online. I heartily recommend this new resource that we have for you to check out. Dr. Mahr, you really hit the nail on the head today for so many people. So appreciate your words. And you can not only, our listeners can not only visit our website for guidelines-based resources on allergy and asthma, but also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology. And you can find their resources at allergyandasthmarelief.org. So thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. For the staff at the Allergy and Asthma Network, this is Sally Schessler. We wish you a great and a healthy day as we work to breathe better together.